Welcome you all to the masterclass program, which is being organized by HKES'S NIJALINGAPPA Institute of Dental Sciences and Research, Kalaburagi. My topic of presentation is TMJ anatomy, mandibular movements, TMJ disorders. I'll be explaining under these headings: overview, terminologies, TMJ anatomy, mandibular movements, TMD terminology and classification, TMJ disorders. Overview. First, I will be explaining about the anatomic features and the physiologic aspect, the biomechanics of TMJ, the etiological features, classification of temporomandibular disorders, followed by the treatment aspect. Terminologies: ligament, strong fibrous and elastic bands that connect bone to bone, providing stability and preventing excessive movement. Example: capsular ligament, collateral ligament, lateral mandibular ligament. Cartilage, it is a soft tissue, gel-like tissue that cushions and protects the ends of bones at joints. White fibrous cartilage, a tough, white and dense cartilage. Type 1 and type 2 collagen fibers, chondrocytes and fibroblasts scattered within the matrix. Excellent tensile strength, resiliency and shock absorption. Elastic fibers, present in the articulating disc at intermediate zone and posterior superior lamina and TMJ capsule. Tendons connect muscles to bones, facilitating movement, transmit the force of muscle contractions to bones. Capsular ligament, it is a fibrous envelope that surrounds the TMJ, attaching to bones and to enclose the joint. Synovial fluid, it is a viscous fluid that lubricates the movable joint. Here, the synovial fluid lubrication, how it lubricates the joint cavity, it is by the boundary lubrication and the weep lubrication. Isotonic contraction of the muscle, it is the muscle that shortens or means that is during contraction or lengthens during eccentric contraction to produce the movement. Isometric contraction, it is the muscle that produces the force, but there is no movement at the joint or change in the muscle length. Arthrocentesis, minimally invasive treatment for temporomandibular joint, inserting needles into the joint to flush out inflammatory debris and adhesions. Deviation, the opening pathway of mandible is altered but returns to normal midline relationship at maximum opening. Deflection, a continuing eccentric displacement of the mandibular midline incisal path, symptomatic of restriction in movement, means it is turning aside. The mandible in an extreme movement will be placed aside or off the midline. TMJ anatomy. The parts are as follows. We can study first about the bones and then the soft tissues. Bones are mandibular condyle, glenoid fossa, and articular eminence of temporal bone and tympanic bone. The first picture, it is the lateral view in which the condyle and the glenoid fossa, and anterior to these two is the articular eminence. The second picture, it is the articular eminence, mandibular fossa, which is also called as glenoid fossa, squamotympanic fissure. The third picture, the condyle, it is in the front view. The condyle can be divided into head portion and the neck portion. The surfaces are posterior, anterior surface. In the anterior surface, the pterygoid fovea, into which the lateral pterygoid muscle will attach. The superior surface is the articulating surface. The fourth picture, that is the infratemporal view. When the imaginary lines are drawn from the lateral pole through the medial pole, in the midline, the two lines meet at anterior margin of the foramen magnum. The last picture, it is the articulating surface. The different zones are, first is articular zone, second is proliferative zone, the third is fibrocartilaginous zone, the fourth one is calcified cartilage zone, the last is subarticular bone, means the condyle. Soft tissues are as follows: outer capsule, articulating disc, in which the parts are anterior zone, anterior band, middle or intermediate zone, posterior band, and posterior bilamellar zone. Bilamellar means it is the superior and the inferior lamella. Cavities, superior and inferior cavity. Surfaces, superior, inferior. Synovial membrane, retrodiscal tissue, associated or assisting ligaments. Those are stylomandibular and spinomandibular ligaments. Arterial supply, venous drainage, and nerve supply are as follows: superficial temporal artery, middle meningeal artery, internal maxillary artery, auriculotemporal nerve, deep temporal, and mesenteric nerve. In the first picture, it is the capsule that envelops the temporomandibular joint. It is attached superiorly to the zygomatic arch and inferiorly to the neck of the condyle. The second picture, it is the frontal cross section, in which we can see the articulating disc and both the medial collateral ligament and the lateral collateral ligament, which are attaching to the neck of the condyle, and outside is the capsular ligament. So the articulating disc divides the cavity into superior and inferior cavity. The third picture is the lateral view. Starting from the anterior, it is the capsule and the articulating disc. To the articulating disc, it is the superior lateral pterygoid muscle which will attach, and even the inferior lateral pterygoid muscle which will attach to the pterygoid fovea. Coming to the articulating disc, it will have anterior band, anterior zone, anterior band, intermediate zone, posterior band, and posterior bilamellar. That is, one is superior retrodiscal lamina, which is elastic in nature, which can stretch to a certain limit, whereas the inferior retrodiscal lamina is firm and it's made up of collagenous fibers. It will have a limited movement or elongation. The last picture is about the retrodiscal tissue, which is highly vascularized. Associated or assisting ligaments are stylomandibular ligament and spinomandibular ligament. The lateral ligaments are horizontal and oblique ligaments. The horizontal portion, actually, it limits the posterior movement of the condyle, whereas the oblique, it limits the rotational movement or the rotational opening of the mandible. Muscles influencing mandibular movements are masseter, elevates the mandible, contributes to protrusion. Temporalis, elevates the mandible, contributes to retrusion. Medial pterygoid, elevates the mandible, contributes to protrusion. Superior lateral pterygoid, stabilizes the condyle and disc during mandible roding, that is unilateral chiving. Inferior lateral pterygoid protrudes the mandible, contributes to lateral movements and mouth opening. Anterior digastric depresses the mandible and elevates the hyoid bone. Posterior digastric depresses the mandible and elevates the hyoid bone. Coming to the physiology of the muscles, this can be studied under two different headings. That is, one is voluntary movements, that is under conscious control. The possible functional movements are opening and the closing, when we speak, when we masticate, and when we perform other function. The involuntary reflexes that can take place are jaw jerk, jaw closing, or masseter reflex. In this, involuntary contraction of jaw closing muscles triggered by sudden stretch or tap on chin. It is a protective reflex mechanism. Jaw opening reflex is triggered by orofacial stimuli. Examples are noxious stimulation on face, teeth, tongue, and oral mucosa. Mechanism, it is inhibition of jaw closing muscles and activation of jaw opening muscles. Mandibular movements. Before we understand the mandibular movements, first we have to know about the functions of the muscles and functions of the ligaments. The muscles will influence the movement of the mandible, whereas the ligaments limits the movement of the mandible. First is rotational movement. Second is translation movements. The rotational movements can be studied in three different anatomic planes, that is frontal plane, sagittal plane, and horizontal plane. When we draw axis along this plane, it is easy to understand. The second picture of the mandible, that is the axis which is drawn superior-inferiorly, it is along the frontal plane. The mandible rotates around the axis. That is possibly when we do right lateral or left lateral movement, the rotational movement can take place. That is the right condyle, it is under rotation. The second picture, which I am going in a clockwise, when the axis is drawn antero-posteriorly on the right condyle, the possible movement of the condyle is on the left side, there is a disocclusion or disoccluding condyle. No, sorry, there is a possible movement of a shift of the mandible towards the downside. And the third picture is the axis which is drawn in a horizontal plane, that is horizontal axis. In this, around this axis, it is the movement of the mandible takes place. Opening and the closing movements are possible. The translation movements are the bodily shift of condylar head, that is possibly the protrusion. Here, both bilateral condyles can shift, whereas in the other sort of movement, it is unilateral movement of the condyle can take place. So next is knowing about the border movements, and within the border movements, it is the functional movements which are possible. These can be studied, same thing with the sagittal plane, horizontal plane, and a frontal plane. In the sagittal plane, the possible movements that the border movements that can take place are, the first is posterior opening border movement, followed by means the anterior opening border movement, and the superior contact border, and the last is the pear shape, what you people are seeing in the first picture, that is fourth one, is the functional movement. In the horizontal plane, it is the left lateral border movement, continued left lateral border with protrusion, right lateral border, continued right lateral border with protrusion. In the frontal plane, it is the left lateral superior border movement, left lateral opening border movement, right lateral superior border movement, followed by right lateral opening border movement. Coming to TMJ biomechanics, I have considered the pictures both from the OKES'S as well as from the dorsum. On the extreme right side and the left side, the pictures are from the dorsum. In the center, that is from the 1 to 8, pictures are from OKES'S. It is the normal relationship of the condyle in the glenoid fossa, and when the movement occurs, means when we start opening the mandible, possibly how the condyle moves from the glenoid fossa towards the articular eminence, and the relationship of the articulating disc with the condylar head. First, on the jaw opening, the first picture, we have to consider the lateral pterygoid muscle functioning. The red plus is the contractile condition of the muscle, whereas blue color negative is the relaxation condition of the lateral pterygoid muscle. The lower head of the lateral pterygoid muscle, once it starts contracting, possibly the condyle movement will start. At this time, the superior head of the lateral pterygoid muscle will be in a relaxed state. The second picture, when the condylar head is on the articular eminence. And the third picture, the lower head of the lateral pterygoid muscle start relaxing, whereas the upper head of the lateral pterygoid muscle is in a contractile condition to stabilize the articulating disc. Coming to the jaw closing aspect, actually, on the left side, the first picture, the lower head of the lateral pterygoid muscle in a completely relaxed condition, whereas the upper head of the lateral pterygoid muscle is in a contractile condition. So, this is the possible contraction and relaxation of the upper and the lower head that usually takes place during the jaw opening and jaw closing actions. So one more aspect of the TMJ biomechanics, what we have to understand is, according to the Oki-san, he uses one terminology, that is orthopedically stable temporomandibular joint. That is, the condyles placed in the glenoid fossa in an anterior-superior position, preferably in the, its relation with the intermediate zone. And when the teeth come in contact, actually, there should not be any sort of pain or discomfort to the patient. Means when the patient closes the mandible and intercuspate, the condyles will be placed in anterior-superior position, and that too in the intermediate zone, and the patient or the subject should not complain of any sort of pain. This is the condition which is called as orthopedically stable temporomandibular joint. So the principles are as follows. Ligaments do not actively participate in normal function of the TMJ. They act as guide wires, restricting certain joint movements while permitting others. They restrict joint movements both mechanically and through neuromuscular reflex activity. Ligaments do not stretch. If traction force is applied, they can become elongated, that is, increase in length. Once ligaments have been elongated, normal joint function is often compromised. The articular surfaces of temporomandibular joints must be maintained in constant contact. This contact is produced by muscles that pull across the joints, the elevators, temporalis, masseter, and medial pterygoid. So, first is about the terminologies before we go through the temporomandibular disorders classification. The first, it was coined by Dr. James Coston. That's why it was called as Coston syndrome. Later, they used to consider the terminology as temporomandibular joint dysfunction syndrome and few others, that is Ramchurd and Ash. They mentioned it as functional temporomandibular joint disturbances. Bell coined it as a temporomandibular disorders, but ultimately American Dental Association, they advised to stick to the terminology temporomandibular disorders. So classification of temporomandibular disorders are, it is as follows. First is masticatory muscle disorders. In that, protective co-contraction, local muscle soreness, myofascial pain, myospasm, centrally mediated myalgia. The second one is temporomandibular joint disorders, which I will be discussing further in detail. In that, derangement of the condyle disc complex. In that, disc displacements, disc dislocation with reduction, disc dislocation without reduction. The second one is structural incompatibility of the articular surfaces. In that, deviation in form, it is about the disc, condyle, and fossa. The next is adhesions, that is disc to the condyle, disc to the fossa. Subluxation, that is hypermobility. Spontaneous dislocation. Inflammatory disorders of the TMJ are as follows: synovitis, capsulitis, retrodiscitis, arthritis. In arthritis, it is osteoarthritis, osteoarthrosis, polyarthritis. Inflammatory disorders of the associated structure are temporal tendonitis, stylomandibular ligament inflammation. The chronic mandibular hypermobility, in which ankylosis, possibly due to fibrosis or maybe due to bony changes, muscle contraction, myostatic, myofibrotic, and coronoid impedance. Growth disorders, congenital and developmental bone disorders are as follows: agenesis, hypoplasia, hyperplasia, neoplasia. Congenital and developmental muscle disorders are hypertrophy, neoplasia. So before proceeding to temporomandibular joint disorders, in general, the etiological factors that causes temporomandibular disorders will be discussed. First is occlusal factors, possibly due to orthopedic instability, acute changes in occlusal conditions, functional and parafunctional activities of masticatory muscles, trauma, it can be macro trauma, micro trauma, emotional stress, deep pain input, and parafunction. See, here are the few examples of the altered condition of the occlusion and the habits and altered the chewing habits that can be a causative factor in TMD disorders. First is occlusal factors. Initially, TMJ will be placed in centric relation. It is being mentioned by Okison as musculoskeletally stable position. During maximum intercuspation, a single tooth contact does not allow the entire dental arch to gain full intercuspation. This will result in a condition called as occlusal instability. But here, TMJ is still in stable position. Since the condyles and teeth do not fit in the stable relationship, at the same time, this results in a orthopedic instability. Before I have explained about the orthopedic stable joint, and here how orthopedic instability can result. You people can observe the pathological events. Next is trauma. Trauma have a greater impact on intracapsular disorders than muscular disorders. Trauma can be classified as macro and micro. Macro, it is the sudden blow, or it can be a sudden fall, or accident, or accidental injury. Whereas microtrauma, it is the continuous clenching, the bruxing, or the parafunctional activities. All these can be a traumatic factor that can be causing a problem to the muscles as well as the temporomandibular joint. Emotional stress, here it is the chronic stress that involves HPA axis. The HPA axis means it is a systemic condition, means that is hypothalamic pituitary adrenal axis, the body's central stress response system, often caused by chronic stress. Means this will involve many muscles of the body, in which the the facial muscles, masticatory muscles are not spared. So this sort of HPA axis will cause increased in the muscle activity, and this will cause a strain of the muscles, and this results in a pathological condition. Deep pain input, that is excited central nervous system, that produces the muscle hyperactivity. This is the examples are like protective contraction or protective muscle splinting. The parafunctional activities are classified into diurnal or nocturnal. The here the muscle hyperactivity is very predominant, and there is increase in static tonic contraction of the muscle. In the terminologies, I have mentioned about the isotonic and isometric contraction. The isometric contraction is pathological, whereas isotonic is more of physiological. The sixth one is the patient adaptability, because every individual will have a different biological system and a different threshold of sustainability. The biologic system that can tolerate a certain degree of variation are factors influencing adaptability are genetic variability. Most resistant people or resistant race, and biologically tissues can adapt, and even the demographic, the different area people will have a different adaptability. Here one table in which the factors normal functional activity and parafunctional activity I've tried to project. The first one is the forces of the tooth contact. In normal functional activity, about 17,200 pounds of forces will be generated per day. Whereas in parafunctional activity, it is 57,600 pounds per day. The second one is the direction of applied force to the teeth. Normally in functional activity, it is the vertical and it is well tolerated. Whereas in the parafunctional activity, it is the horizontal forces which are generated, but they are not well tolerated. The third one is mandibular positions. In the functional activity, the centric occlusion, relatively stable. What it is being mentioned, the orthopedically stable joint, orthopedically stable occlusion. In parafunctional activity, more of eccentric movements will be taking place, which results in instability or it becomes more unstable. Type of muscle contraction, which I have mentioned it before also. Here in the functional activity, it is isotonic, means when the muscle contracts, there will be shortening of the muscles. It is physiologic. Whereas in the parafunctional activity, it is the isometric contraction, means there will be contraction of the muscle fibers, but there is no shortening of the muscles. This is non-physiologic, means it is pathologic condition. Influence of protective reflex, it is present in the functional activity, which I have mentioned, jaw opening and a jaw closing reflexes which can take place. Whereas in parafunctional activity, it is obtunded. The sixth one is the pathologic effects. Functional activity is unlikely, and in the parafunctional, it is always or very likely. Coming to the examination part of particularly about the temporomandibular joint disorder conditions. I stick to the temporomandibular joint disorder conditions. In this, first is the visual examination, followed by palpation. In the visual examination, we have to check opening and the closing movement, and we have to observe the deviation and the deflection. The picture A is deviation, means the mandible moves to one side, and at the extreme opening it comes back to the midline. Whereas the picture B, here the mandible in an extreme movement, it is being placed on one side. So when we do examination, means that is palpation actually, we have to palpate the condyle, the lateral poles, and we should ask for the sign of pain. Followed by, should be able to palpate the sounds of the temporomandibular joint. Click. It is a short sound or a short duration sound that is possible. And whereas crepitations are continuous sounds. And next is the joint restrictions. That is, the dynamic movements of the mandible are observed for any irregularities or restrictions. The mouth opening also is being checked and recorded, because here mouth opening, how it will help in differential diagnosis. We'll take one example. If there is a pathological condition of the temporomandibular joint, the patient will have a restricted mouth opening, and they will have only to certain limit of mouth opening. Whereas a pathological condition, if it exists with the muscles actually, placing two fingers, one on the maxillary incisors, one on the mandibular, applying a slow force or pressure, downward force, will slowly improve the mouth opening. So if the patient is possibly able to do the mouth opening, so that pathological condition is related to the muscles. If patient is not able to open the mouth, then it is related, the pathological condition is related to temporomandibular joint. So another few tests or the investigations clinically that what we can perform is, one is load testing, the bimanual manipulation of the mandible. When we load the mandible, means when we manipulate the mandible and placing the condyles in centricrelation position, the condyle will be placed in the intermediate zone where it is least innervated. The patient should not experience any sort of pain, and if patient doesn't complain of any pain, it is not a temporomandibular joint disorder. If patient complains of pain, then it should be considered as a pathological condition. And one more clench test, the tongue blade need to be placed when patient complains of pain on a particular side. So here one example is being considered. The patient, if they complain a right side pain in the temporomandibular joint area, first the tongue blade need to be placed between the teeth and should ask the patient to bite or occlude. So this will help in decreasing the load on the right side temporomandibular joint. So if patient gives the opinion of reduction in the pain, then it is related to the right temporomandibular joint. And then the tongue blade need to be moved to the opposite side, that is the left side. And once again, the patient is asked to clench or occlude the teeth. And if patient complains of pain, then it is due to the loading of the right temporomandibular joint that is causing the pain. So this test also will help in differentiating the temporomandibular joint disorders. Next, it is mandatory to advise the other investigations like OPG, lateral ceph, transferential, transcranial, anteroposterior, CT, MRI, and CBT. It depends on the pathological condition. Only the required radiographs should be advised and should be considered. Here I like to mention MRI will reveal the condition of the articulating disc, the pathological condition. The next is the mounted cars in centriculation will help clinician to check the occlusal interferences. Next is I'll be discussing the functional disorders of the temporomandibular joint. First is disc displacement. Here you people have to keep observing the pictures of that respective condition, the condyle and the articulating disc. The first is disc displacement, history, trauma with joint sounds, pain may or may not be present. Pain may or may not be present. Clinical features, during opening and closing, a click, that is the joint sounds is possible. Normal range of jaw movements are seen. Pain may or may not be present. Treatment is anterior repositioning appliance. Disc dislocation with reduction, etiology, macrotrauma or microtrauma or orthopedic instability. History, long history of clicking, joint sounds in the joint, catching sensation in joints. Catching may or may not be painful. Clinical features, deviation in the opening pathway, limited range of motion before reduction, normal range of movement after reduction. A sudden loud pop, a closing click near the intercuspal position. Treatment is definitive treatment, stabilization appliance. If this doesn't subside the discomfort or pain, so this means we can think of anterior repositioning appliance. Supported treatment is soft food, slow chewing cycles, analgesics, moist heat or ice pack. The right picture you people can see during the opening, a click is possible and the disc is being placed more anteriorly to the condylar head, and even in the closing also the click is possible. This dislocation without reduction is also called as closed lock. Please kindly observe the right side picture, the position of the condyle, the position of the articulating disc. Etiology is microtrauma or macrotrauma. History, patients, most of them report exact onset of this disorder, a sudden change in range of mandibular movements, gradual increase in intracapsular symptoms, clicking or catching prior to the dislocation. Clinical features, limited mandibular opening, preferably only to 25 to 30 millimeters. Normal eccentric movement to the ipsilateral, restricted eccentric movement to the contralateral side. Maximum opening, it is a hard hand feel. Means clinically, when we palpate the mandible, it is really the hard feeling a clinician will observe. Definitive treatment, manual manipulation, attempt of reducing or recapture. Because here, manually, first we have to manipulate the mandible, that is, placing the thumb in the second molar area, applying a downward force, and with the fingers supporting the mandible and pushing the mandible posteriorly. That will help in recapturing of the condyle into the glenoid fossa. This is manual manipulation. If the lateral pterygoid is active by pain or dysfunction, injection of local anesthesia should be considered. And this will help in reduction of the disc. Next is education and motivation for the patients is very important, because here the patient will be able to assist by himself or herself to do the reduction of the mandible. Here, one thing should be kept in mind: anterior repositioning appliance is contraindicated. Means the dislocation without reduction. In this condition, anterior repositioning appliance is contraindicated. Supportive therapy, not to open too wide, decrease hard biting, non-steroidal anti-inflammatory drugs, heat or ice therapy, surgical correction. And I want to mention how the heat therapy will help in reducing the pain. The heat therapy will increase the blood flow of that particular area, and it reduces the toxin as the blood flows. And this is the mechanism that takes place when heat therapy is advised. In the last, surgical corrections is indicated. Structural incompatibilities of the articular surfaces are adherences and adhesions. Adherences, a temporary sticking of articular surfaces. Note, prolonged static loading of the joint. This is one condition actually, that's what being mentioned. Adhesion, permanent sticking. Here, produced by development of fibrous connective tissue. So, two different entities. In adherences, it is due to the prolonged static loading of the joint will result in adherences. Whereas adhesion, which is permanent, it is due to the fibrous, means development of the fibrous connective tissue. History, adherences, morning jaw is stiff until they pop it once. Adhesions, a limited opening. Clinical features, a chronic fixed disc during closure, inability to achieve occlusion, a stiffness or catching on the way to maximum opening. Definitive treatment, stabilization appliance at night, physical self-regulation, arthroscopic surgery. Supportive therapy, passive stretching, ultrasound is advised. In these pictures, in the first row, it is the adherence between the articulating disc and the glenoid fossa. That is the superior joint space. Adherence in the superior joint space. So here, the posterior dislocation of the disc and the permanent adhesion, which you people can see in the second row. So permanent sticking of the articulating disc to the glenoid fossa. So the last row is the adhesion, the adherence between the articulating disc and the articulating surface of the condyle. Subluxation, it is also called as hypermobility. It is not a pathological condition. It is just a anatomic variations of the articular eminence or posterior slope of the articular eminence. Etiology, short, steep posterior slope of articular eminence, longer, flatter anterior slope of articular eminence. History, jaw goes out anytime during wide opening. Third, a dull, heavy joint sound is possible. Clinical features, condyle displaced forward, leaving a small depression in the face behind the condylar head that can be clinically appreciated or when we do the palpation. Mandibular deviation greater and much closer to the maximally open position. Definitive treatment, surgical alteration of the joint, example, eminectomy. Supportive treatment, restriction of opening movement, intraoral device to restrict the movement. Luxation, it is also called as open lock or a spontaneous dislocation. On the right extreme, you people can see one is the clinical picture of the patient, which is in a open mouth condition. And even in the radiograph, the condyle are being displaced more anteriorly. It is anterior to the articular eminence. Hyperextension of the joint results in open mouth position with fixed joint preventing translation. Etiology, contraction of superior lateral pterygoid during full limit of translation. Lack of superior retrodiscal lamina to retract the disc. History, wide opening of mouth, pain with dislocation. Clinical features, sudden and locked position of mandible in wide open mouth. Anterior teeth are separated with posterior teeth in a closed position. Definitive treatment, manual manipulation, increasing the disc space, slight posterior pressure applied to chin. So this can help in managing to occlude the teeth. Thumb placed in molar area with the downward pressure, that is manual manipulation. And so if these treatment will not help, then we have to think about the surgical procedure. Supportive treatment, prevention of extreme opening, training to the patient about reduction technique. Inflammatory joint disorders, types, synovitis, capsulitis, retrodiscitis, arthritis, in that osteoarthritis, osteoarthrosis. Polyarthritis, arthritis, in which rheumatoid arthritis, psoriatic arthritis, hyperuricemia, rheumatic arthritis, infectious arthritis. Synovitis and capsulitis, these are inflammation of synovial tissue or capsular ligament. These two conditions can be distinguished only by visualizing the tissue through arthroscopy or arthrotomy. Etiology, trauma, macrotrauma, or it can be microtrauma. Infection from adjacent structure. Clinical features are pain in front of the ear. Lateral aspect of the condyle is tender on palpation. Definitive treatment is no definitive treatment. Protect the joint from any further injury. Preferably for any athletes, sports person, we have to advise to use the athletic appliance. Supportive treatment, restrict all mandibular movements, soft diets, analgesics, moist heat, ultrasound therapy is advised. Retrodiscitis. Etiology, trauma, it can be extrinsic or intrinsic. History, gradual onset of pain problem, progressive onset of clicking and catching. Clinical features are constant pain around the ear increases with jaw movement. Swelling of the retrodiscal tissue leads to loss of posterior occlusal contact on ipsilateral side, results in malocclusion. Definitive treatment, no definitive treatment. Care should be taken to protect the joint. Supportive treatment, analgesics, ultrasound therapy, intracapsular injections of corticosteroids, restrict the movement, soft diet, intermaxillary fixation to re-establish the occlusion, anterior repositioning appliance. Arthritis, it is the inflammation of the articular surface of the temporomandibular joint. The right side, the radiographs in which you people can see the arthritis, osteoarthritis conditions. The types are osteoarthritis, osteoarthrosis, polyarthritis. Osteoarthritis, overloading of articular surfaces, compromised disc due to dislocation and retrodiscitis. History, unilateral joint pain aggravates by doing mandibular movements, constant pain. Clinical features are limited mandibular opening with joint pain. Crepitations can be palpated. On palpation of lateral bone, pain will increase. Definitive treatment, mechanical loading should be decreased. Anterior repositioning appliance is advised. Supportive treatment, analgesic plus an anti-inflammatory, soft diet, thermotherapy. That is, it can be heat or it can be cold or both. Osteoarthrosis, etiology, joint overloading. History, symptoms are not reported by the patient. Clinical features, no significant clinical features. Structural changes in the subarticular bone are seen in retrodiscal tissues also. Definitive treatment, it is an adaptive process. No treatment is indicated. Polyarthritis, rheumatoid arthritis. Etiology, systemic disorder, that is autoimmune disorder. Definitive treatment is medication by rheumatologist. Supportive treatment is stabilization appliance, arthrocentesis, arthroscopic procedures. In rheumatoid arthritis, the clinical features are as follows. Severe cases, significant loss of condylar support can be seen. Acute malocclusion, heavy posterior contact of teeth with anterior open bite also observed. In psoriatic arthritis, it is an autoimmune disorder. The clinical features are pain and stiffness and the swelling. Treatment, no definitive treatment. Supportive treatment, it is treatment by rheumatologist, general physician, and followed by physical therapy, non-steroidal anti-inflammatory drugs, moist heat, and ultrasound therapy. Hyperuricemia etiology, dietary changes will result in high levels of serum uric acid. Clinical features are old persons, affects both joints. Pain may or may not be increased with movements. Definitive treatment, lowering serum uric acid level, best managed by physician. No supportive treatment. Traumatic arthritis, etiology, sudden macrotrauma. Clinical features are limited mandibular opening, secondary to pain. Acute malocclusion may exist if swelling of joint is present. Treatment, no definitive treatment. Mouth protectors for sports person. Supportive treatment, rest, restricted movements, soft diet, moist heat, ultrasound, NSAIDs, stabilization appliance. Infectious arthritis, etiology, systemic disease or immunologic response. Immunologic response. Clinical features are constant pain, accentuates with the movement, and joint swelling is observed. Definitive treatment, antibiotic medications. Supportive treatment, increasing normal range of movement to prevent fibrosis or adhesions. Passive exercise is advised. Inflammatory disorders of associated structures are as follows. Temporalis tendinitis, etiology is muscle hyperactivity. Clinical features are restricted jaw opening and pain during jaw closing. Definitive treatment is stabilizing appliance, supportive treatment, analgesics, and anti-inflammatory drugs. Ultrasound corticosteroid injection into the tendon. Inflammation of stylomandibular ligament, pain at the angle of mandible. This is the clinical feature. Treatment, in the definitive treatment, it is the rest, which is advised for the patient. Means it is to limit the mandibular movements, extreme movements. Supportive treatment is analgesics and anti-inflammatory. Chronic mandibular hypermobility are as follows: ankylosis, intracapsular surfaces of the joint develop adhesions that prohibit normal movement. Etiology, macrotrauma, clinical features, movement restricted in all position. Muscle contracture, first one is myostatic contracture. In this etiology is a muscle is kept from fully lengthening, stretching for a prolonged time. Clinical feature, painless limitation of the mouth open. Myofibrotic contracture etiology, tissue adhesions within the muscles or its sheath. Myositis. Clinical features, painless limitation of mouth opening. Lateral condylar movement is unaffected. Coronoid impedance etiology, coronoid process extremely long or fibrosis. Clinical features, it is limitation in all movements, especially in protrusions. If coronoid process is free, that is unilateral. Deflection of the mandible to the same side. Growth disorders, agenesis, hypoplasia, hyperplasia, and neoplasia. Coming to the conclusion. So here, the factors that cause the TMJ disorders or TMD disorders. The interrelationship of the different conditions that can aggravate one on other. It is being represented or being explained in the by the Okeson is as follows. That is, when there is a disc derangement disorder, even it can cause masticatory muscle disorders, or a masticatory muscle disorder can cause a disc derangement disorder. And disc derangement disorder will have an influence on the inflammatory disorders. So that is, when masticatory muscle disorder persists, limited mandibular movement can become protracted and lead to chronic mandibular hypermobility disorders. Likewise, inflammatory disorders can also induce chronic mandibular hypermobility disorders. The second, same thing, that is the disc derangement disorder will have an influence or can cause the masticatory muscle disorders and the mandibular hypermobility disorders, and disc derangement can cause inflammatory disorders. So for all these disorders, the main factor is trauma. Trauma is, it can be macro trauma or a micro trauma. As a prosthodontist, when patient comes with a complaint of pain, discomfort, and dysfunction of jaw opening or restricted movement or pain in the TMJ area or the temporal area or the masseter muscle area, clinical examination, advising investigation, and coming to the proper definitive diagnosis will help in treatment planning. In the treatment planning, one is just we can advise a stabilization appliance, anterior repositioning appliance according to the Okeson, whereas the Dawson, he classifies the occlusal appliances into definitive and permittive. Even a selective grinding therapy also can be considered, and more definitive or really a complete reconstruction, if it is required, it is possibly with the fixed prosthesis. So it is a multidisciplinary approach in which we have to consider the different specialty people, means the specialists, and the collective information. With the collective information, the treatment has to be rendered so that the patient will be able to perform normal functions. Thank you all. I thank you first for Indian Prosthodontic Society, Karnataka State Branch, and the HKES'S NIJALINGAPPA Institute of Dental Science and Research, Kalaburagi, for providing opportunity to present this topic in the masterclass program. Thank you, one and all.